Yaman Meringue. I hope you're well today. My name's Alison Barnes, and we're here today to talk about diabetes in community and public health. So we need to have a little look at the difference between the various types of diabetes. That would be type 1, type 2, and gestational diabetes. Have a look at the clinical manifestations and a review of the pathophysiological processes involved with diabetes, like how diabetes works. Just a quick review, nothing serious. I don't teach pathophys. We need to describe the acute complications for hypoglycemia and hyperglycemia and look at the implications for not just the individual, but for the broader community. So looking at it from a public health perspective. And we need to describe the chronic implications associated with diabetes. And I haven't put it on here for learning outcomes because I forgot, but we also need to have a little look at diabetes from the perspective of both the individual and the public health response in the context of Palestine. So diabetes mellitus, which is the technical name in English. The word mellitus is a commonly left unspoken, and often it is simply referred to as diabetes because it's much easier to say. The definition of diabetes is that it's a group of metabolic diseases with high levels of blood glucose over a prolonged period of time. The causes are different, mostly, but you do eventually have the same side effects. So type 1 diabetes is characterized by a complete destruction of islet cells in the pancreas and an inability to produce insulin. So your body makes little to no insulin. Type 2 diabetes is characterized by insulin resistance at the target cells. I could describe it more, but I don't want to confuse anybody. And I'm going to trust the process. You are studying to be nurses. You will have, at some stage, had a deeper look into diabetes. And eventually, diabetes may progress to insufficient pancreatic insulin release and islet cell destruction for both types if it's not managed adequately. So looking at this diagram, some of the that's working. Just move that out of the way. There we go. Just moving all the little pop-up boxes out of my way. So some of the main symptoms of diabetes, and the ones that are listed here, looking at body systems or organs. The ones in blue are more common in type 1 diabetes. So often, for example, with type 1 diabetes, when you get that really fast hyperventilation, hyperventilation is fast breathing. Anyway, when you get that small breathing, it's hyperventilation, really fast respiratory rates, and it's kind of shallow. That is often associated with diabetic ketoacidosis. So it's one of the mechanisms your body uses to try to correct the acidosis. Weight loss is a systemic response that is commonly seen in type 1 diabetes, and that sweet, kind of slightly fruity breath smell is it's acetone, but it does smell a little fruity. that's again a symptom of diabetic ketoacidosis. Nausea, vomiting, and abdominal pain. They say that's more common in type 1 diabetes, but I've also heard many patients complain about those things in type 2 diabetes, particularly nausea and vomiting, and polyuria and polydipsia, so excessive thirst and frequent urination, again, are symptoms of diabetic ketoacidosis. And blurred vision is common in both type 1 and type 2 diabetes, and can be a symptom of gestational diabetes, which is most similar to type 1 diabetes. It's a side effect of pregnancy. Not a good side effect, though. So homeostasis of blood glucose levels. It's important to understand that diabetes, whatever the type, it's about an abnormality in homeostasis of blood glucose. That's kind of the end result of the disease. So insulin and glucagon have opposing effects on blood glucose levels. Insulin lowers blood glucose or blood sugar levels by facilitating glucose uptake and storage in the cells. So when you eat too much, you have an excessive amount of glucose in your bloodstream. So your body takes that blood glucose and turns it into fat cells. That's what they mean by storage. Glucagon, on the other hand, decreases blood glucose levels by releasing glucose into the bloodstream. There is a constant balancing between levels of insulin and glucagon to maintain homeostasis in blood glucose levels. And this little diagram is just a look at how that works in a bit more detail. So in diabetes mellitus, the function of insulin, which is secreted by beta cells of the pancreas, it binds with the insulin receptor on the cell surface of the target cell. Glucose transporters become available in the cell membrane, and transport molecules allow glucose to be taken from the bloodstream, where's my hand so you can see it, into the cells of your body. And thus your blood glucose level is lowered. This diagram with the red stripes they're meant to be blood vessels. It's not very good. Medical diagrams often are not. But it's just a representation of that. So some acute complications of hypoglycemia, so a low blood sugar level. You get an excess of insulin. This is something that's actually most common after you've had an insulin injection, like you've overdosed on insulin. It could be because you've done a more than usual amount of exercise. It could be an inadequate carbohydrate intake. And it's not just any old carbohydrate, it's the right kind of carbohydrate. So if you have, for example, a cup of white sugar or 100 grams of white sugar, your blood sugar level will spike and you will become symptomatic of hyperglycemia almost instantly. But if you have sweet potato, orange sweet potato, or corn, these are low glycemic index foods. So your blood sugar level will be more stable. It won't spike up and down. But if you don't have enough of any kind of carbohydrates, you will spike when you eat anything because your body goes, oh, sugar, yay. but then it crashes quite quickly, and that's when you have a hypoglycemic episode. If the level drops to 2.5 millimoles per litre and remains untreated, becomes a medical emergency and can progress to brain damage, seizures, coma, and death. Alarmingly rapidly. You think it might take a while for that to happen, but it actually happens fairly quickly. Relatively speaking. And if the patient is left untreated. An immediate replacement of glucose is the initial treatment. You need to initially give a quick-acting carbohydrate, such as glucagon, or a glucose, like a bag of IV fluid with a high level of glucose in it, or half a glass of fruit juice, or a teaspoon of honey, or a couple of teaspoons of sugar, or jelly beans, they're almost 100% sugar. After waiting approximately 15 minutes, you may need to re-administer a quick-acting carbohydrate, or if their blood sugar level is okay, you can add a slow-acting carbohydrate, such as a sandwich or a couple of biscuits or a piece of fruit. Probably wouldn't use fruit because actually most fruits have fairly short-acting carbohydrates. Or commence them on an intravenous glucose drip. The use of glucagon is generally reserved for people who have type 1 diabetes, because for people with type 2, it messes with their blood sugar levels way too much. And the way to prevent this problem is to have fairly regular, have more close monitoring of your blood glucose levels. So, for example, people with type 1 diabetes may only check their sugars once a week if your HbA1c, oh, I can't remember. There's a measure of long-acting, you'd think I know I have type 2 diabetes. You'd think I can remember. My memory is so much worse than normal. Anyway, so you might have HbA1c3. You might have a relatively stable HbA1, the long-acting measure of blood glucose levels. It looks at an average, it's kind of an average over many weeks. If that, and it may be called something different in your jurisdiction, if you measure that and it's quite stable, you might be told it's okay to do your BSL or BGL once a week. Your diet's good, you're not sick, you don't have any, you don't take any medications that can mess with your blood sugar levels, it might be fine to do it once a week. But if you start having hypos because you're not eating properly or you're doing more exercise than normal, it may be recommended to you to check your blood sugar level more, or blood glucose level more frequently. So some acute complications of hyperglycemia. Hyperglycemia always indicates poor diabetic control, insufficient insulin, and it doesn't matter whether that's what sort of diabetes you have, that's just the rule, you have poor diabetic control. It can be the result of some medications, such as steroids. Steroids can mess just very alarmingly with blood glucose levels. And something that there's been some research out of Egypt on this, for people who have long COVID or acute episodes of COVID and who have diabetes, you can suddenly develop, they're referring to it as fragile diabetes. Your blood sugar levels can fluctuate quite wildly for no apparent reason. if you have an increase in the insulin counter-regulatory hormones such as adrenaline and cortisol, so that could be the result of an acute. Cortisol is a stress hormone. So if you have, as is adrenaline, it's part of the flight or fight response. You get a release of adrenaline. So if you have an especially stressful time, your blood sugar control might go out of whack. For example, a few weeks ago, well, nearly a month ago now, more than a month ago, time has no meaning sometimes. I had a car accident and I could feel, you get that surge of adrenaline. It's the fight or flight response. And then you have I spent a little bit of time in hospital. So you have this elevated cortisol and I could feel my sugar levels. It makes you feel very woozy. I could feel them moving around. It's unpleasant. In response to these hormones, hepatic glucose production increases and peripheral glucose usage decreases, resulting in hyperglycemia. Conditions relating to hyperglycemia include diabetic ketoacidosis, which is most common in type 1 diabetics, but can happen in type 2 diabetics, can't speak, particularly if you have fragile diabetes, hyperglycemic, hyperosmolar state, which is most common in type 2 diabetics. It could be because of treatment, over-treatment, so overuse of insulin. It could be that you've forgotten to take your oral hypoglycemic agents, and it could be because you've had a range of acute illnesses such as nausea, vomiting and diarrhea, or gastroenteritis, or you've needed surgery and you've had to fast. You know, there are a couple of potential causes. So some long-term complications related to diabetes. You tend not to get long-term complications from hypoglycemia, mostly because eventually you will pass out and hopefully someone notices. But persistent high blood glucose levels can be very damaging to various body organs, as we discussed earlier, particularly if it's left unmanaged for a long time. And people can have alarmingly high blood glucose levels and not know. And then other times you have only very mild elevations in blood glucose levels and it can wipe you out completely. You get very sick very quickly. So you can never tell. So always check blood glucose levels. If you have anyone who is diabetic, anyone over age of about 50, 45 even, I'd go with 45. Particularly for First Nations people, we tend to have a higher incidence of especially type 2 diabetes. And that's First Nations people the world over. I don't know why, it just is. So you can pretty much divide the complications of diabetes into three section types. You can have microvascular complications, which affect the small capillaries. You can have macrovascular complications, which are associated with larger diameter vessels. And you can have neuropathies, damage to nerve fibers. They can be peripheral or autonomic. Or you can get super unlucky and have all three. I don't know why I smiled when I said that. So organs impacted by diabetes, particularly complications of diabetes, you can have strokes, atherosclerosis, so you get hardening of the arteries. You can have cataracts or diabetic retinopathy. You can have increase in arrhythmias and myocardial infarctions. You can get nephropathy and increasingly frequent kidney infections. You can have neuropathy. For men, it can involve impotence and infertility. You can have urinary incontinence. And you can have problems with your autonomic nervous system. You can develop peripheral neuropathy. So that's where people with diabetes get numbness and weakness particularly in their lower legs, so feet. You'll often see older people and they kind of drag one foot. Almost always that's either because there are two causes, almost inevitably. It's one of two causes. They've had a stroke and they haven't had a complete recovery. They've had a partial recovery, or they have numbness and weakness in their feet. When you're looking after patients in a clinic, it's always a good idea, if you're admitting someone, to just check the toes of their shoes. If there's scuffing on one toe in particular, it's a good idea to check for diabetes. And random blood sugar levels can be a good indicator. And people with diabetes can develop peripheral vascular disease. And if it's left untreated, then the diabetic illness is not managed adequately, people will often they'll lose a bit of a toe and then a whole toe and then a bit more, because they'll get ulcers that don't heal and it will develop into gangrene, and they end up losing lower legs. And you might think to yourself, how does that happen in this day and age? People can be remarkably stubborn about managing their diabetes, and remarkably stubborn about it's not just about managing their diabetes, but it's about actively participating in their illness. Because people will say to you, I've had people say this to me in the clinic, but sister, I take my medication. Yeah, all of the metformin in the universe is not going to fix your problems if you live on a diet of takeaway food. And I live in Australia, so I'm talking about stodgy Western takeaway food, hot chips and chocolates. You can't live like that when you have diabetes. It just becomes not possible if you want to continue living. That's a first world problem. I apologize about talking for food if you don't have enough right now. So what's the nurse's role in diabetes? So we have roles, whether we work in a hospital or we work in a community health setting, such as a general practice or a clinic, an outpatient clinic. So we have roles in assessment, in managing fluid balance, particularly for inpatients. It's harder to do that for people when you're working in a clinic, but you can talk to people about that. We need to look at metabolic acid-base balance, diabetic ketoacidosis is or causes, one or the other, an acid-base imbalance. We, in both community and hospital settings, we have a role in referring patients. So if you have a patient come in to your hospital with complications of diabetes, even if we can't make the referral, we can talk about with the doctors the need for a referral to a diabetes service. We can offer psychological support. Being in your 50s and diagnosed, or late in your 40s or 50s, and being told you have type 2 diabetes can be quite challenging for some people. Well, really, I think it's challenging for everyone. And it can be, even if you've had the disease for a little while, it can remain challenging, psychologically challenging, because sometimes you do all of the right things and still your blood sugar levels are all over the place. And that could be because of medication or other comorbidities, other diseases that you may have. So it's so prevalent, it's easy to dismiss diabetes and wonder why people get upset about being diagnosed with it. But it can make life very difficult. And if you have people who live on very low fixed incomes in places where fresh food is scarce and where access to good quality medical care is very limited, good quality healthcare, because it's not just about the doctors, is it? It can be hard for those people to adequately manage any chronic illness. And I'm not saying we need to dismiss those people by any means. But I think what we need to do is not just look at the patient, we need to look at the social determinants that are impacting our patients so that we can develop a better understanding of why they're sick, why they're not getting better, why are things challenging, and and leading from that, once we've figured that out, we need to ask, what can we do to make it better? For example, there's an Aboriginal medical service. So in Australia, our First Nations people, only since 1972, it's not that long ago, we've had Aboriginal medical services. So these are services that are medical services, like general practice, primary care kind of settings, that are owned and run by Aboriginal people. And increasingly, the staff in these services is Aboriginal, because now we have more and more people going to university. Woohoo! I think that's a great thing. So I've lost my train. Increasingly, Aboriginal medical services here are offering, they're kind of a one-stop shop. You can have all of your health needs met in the same place, except for hospitalizations. But increasingly, Aboriginal medical services are realizing it's not good enough just to offer medical or nursing or podiatry or dentistry, whatever. Health services alone are not going to fix their patients' problems. They need to be creative and think outside the box. So down at Campbelltown, in a service I used to work quite closely with, once a week they do fruit and veg boxes, and you pay your $20 or $25 and you get a box of fruit and veg, which is enough to get by for a week for a family. You can buy two if you've got a big family, but $20 or $25 is very cheap. Normally, the size box would be closer to $50 in Australian currency. So it's not just about telling people that they need to have good food. They need to eat better, because you've got diabetes now, you need to eat better. But it's about making sure they can. There's a program run by most of the Aboriginal medical services here in New South Wales called Too Deadly for Diabetes. It was developed by an exercise physiologist, Dr. Raymond Kelly. And Ray, great person here. And it's a little bit about racism. It's a lot about racism. But here in Australia, there has for a very long time been this attitude that Aboriginal people, if they get diabetes, they don't know how to manage life with diabetes. They're not going to manage themselves properly. They just get sicker and sicker, and we need to give them more and more medication. And that's been what has happened here for a long time. It's also based on a lie, because Aboriginal people do know how to, they do know how to manage diabetes. They just may not have the capacity to do so, whether that's financial or the ability to get to shops where there's good food because they live in quite remote places. Or it could be that they are on a very low fixed income and they've got 8 kids that they've got to feed, for example. So anyway, one of the things that Ray did was he developed Too Deadly for Diabetes, and he taught people how to eat well on limited budgets and how making small changes can have a big impact. Doing things like not putting sugar in your cup of tea. Because like lots of groups of people on very low budgets, particularly in countries that were colonized by the British, cups of tea laden with sugar are often one of the main food groups, particularly for women, because you want to give all your food to the kids who get hungry. So teaching people not to have sugar in their cup of tea, teaching people about matching exercise with caloric intake, teaching people how to understand about glycemic index and making sure that they're not just eating high glycemic index foods like super processed white bread or living on bread because you can buy it for $1 a loaf at the local bakery. But if you spend a few more dollars, you can be fuller for longer and it actually doesn't work out to cost anymore. Anyway, I've lost my train of thought there, but anyway, we also need to help nurses also have a very big role to play in education about diet, exercise, all of those things I've just been talking about. I think I was rambling. Sorry. We need to make sure that patients with diabetes, whether it's type 1, type 2, or gestational diabetes, understand about sick day management, which is just having a plan for if you get sick so that you can avoid going to hospital and costing the community more money because you've been sick and your diabetes hasn't been managed whilst you were sick and you've ended up in hospital. Keeps people out of hospital, doesn't cost the community as much money. It's really simple to do. And it gives people more realistic parameters. So let's say you get COVID and you have really high temperatures and you get gastro with it and you don't know how to manage that with your diabetes. It's about making sure that you understand if you're sick, you need to take your sugars more, you need to drink more fluids to help replace them, the fluids that you're losing because you've got a high temperature and gastro. Yeah. Having a plan makes a big difference. Keeps people out of hospital, doesn't cost the community as much money. We need to help our patients understand the importance of lifestyle changes, and that boils down to understanding diet and exercise. And we need to monitor our patients for side effects. I have diabetes, and just recently I got an ulcer on the top of my foot. It was a blister. It wasn't an ulcer, it was a blister. And one of the things I know to do, because I'm a nurse, is monitoring myself to make sure that that blister heals and it doesn't become infected or ulcerated or any of those things. That would be a side effect. But I knew to monitor for that. And I knew how to dress that wound appropriately to encourage healing. We need to do that for our patients. So the National Institute of Health and Care Excellence, which is a British organisation, has listed some normal values for patients with diabetes. In America, they measure it in milligrams per DL, and in Australia, we measure it in millimoles per litre. And this little chart just shows you the difference, because I talk in millimoles per litre because that's what I'm used to. And I never did get around to checking what unit of measurement you use in Palestine or the Middle East more broadly. I'm going to hope it's millimoles per litre, because then what I'm saying will make more sense to you. Anyway, fasting plasma glucose level. So if you draw blood, should be between 5 and 7 millimoles per litre. And plasma glucose levels before meals should be between 4 and 7. In Australia, we say 3.5 to 7.5 millimoles per litre. And some people will tolerate a slightly higher reading after meals or at other times of the day. I think our bodies are designed to maintain homeostasis. I really think we should be doing that. But then I do it for myself. So, what would I know? So these are some blood glucose charts. In New South Wales Health, we have a system called Between the Flags. And this chart in the middle reflects the Between the Flags chart. There's a white zone, which is normal limits. There's a yellow zone, which is, I think of it as the watch and act. Watch it, monitor it more closely. If it changes, act fast. And then there's the red zone, which is an emergency situation. But it's just a way of alerting the practitioner that, the patient's blood glucose level is outside the normal limits. And a lot of countries have charts like this now. It helps reduce the incidence of patients crashing on the ward. I would strongly recommend checking the charts that your organisation uses when you start work in a hospital. Patients in the community will keep some kind of blood glucose log. Some of the newer blood glucose monitors, you can plug them into the computer and it downloads the information on the computer. Not everyone has that technological capability. So you might see a blood glucose log that looks a lot like this. It's just got date, time, pre or post meal, whether you're sick or not. It can be added in the comments section. And this is just a little bit more of an explainer about the sick day plan. As I said earlier, a sick day is when you have an illness or infection to manage, as well as your diabetes. It could be the cold, influenza, gastro, or a respiratory infection. COVID in particular, as I've also said, does tend to mess with your blood glucose levels. You may need to make changes to your usual diabetes management to help prevent your blood glucose levels from going too high or too low. These changes are usually only needed until you become well again. We have Diabetes Australia and Diabetes New South Wales has a chart that you can get your doctor or the practice nurse to fill in for you, the clinic nurse to fill in for you, so that you know what you're supposed to be doing and when you're supposed to be doing it. It's handy. And when I used to work in clinics, I used to encourage patients to keep it, to stick it on your fridge. We're a nation of sticking things on your fridge. But keeping it somewhere handy. It could be inside your medicine box. It could be stuck inside your medicine cabinet, or whatever works for you. Keep it handy so that you can refer to it if you become sick, and you don't need to stress about it because it's right there. So why am I talking about diabetes in a community and public health tutorial lecture? Well, thank you. I would be delighted to answer that question. The prevalence of diabetes in Palestine is high, with an estimated range from 15.3 to 23.4. It's much higher than the global prevalence of 6%. However, some sources suggest the rate could be as high as 23.4%. It's hard to know, particularly at the minute. The most recent guaranteed accurate figures I could find were from 2010 to 2011, and there was a survey that showed 9 out of 10 Palestinians had at least one risk factor for diabetes, heart disease, stroke, or cancer. There are many challenges facing people with diabetes in Palestine today, and there are many factors that have contributed to the rise of non-communicable diseases in Palestine, including political instability, lack of access to healthcare, and food insecurity. So, who's around to help? So the Palestine Diabetes Institute has clinics in Nablus, Hebron, and the West Bank, and the PDI provides Palestinians with greater access to treatment. There's the World Diabetes Foundation, which has worked in Palestine for over 2 decades now, adopting the diabetes comprehensive care model and empowering refugee communities, and as always, UNRWA as a provider of a significant percentage of primary care services has and continues to, or at least tries, to provide care for Palestinian people. That might become increasingly difficult for them for political reasons, but I'm sure they will continue trying. So there are 2 levels of interventions for people who have or are at risk of developing diabetes. And many of these personal interventions are commonly referred to as lifestyle interventions, either alone or in combination with one or more intervention and or medication. These things can stop people from developing diabetes if you have a HbA1c3, whatever the number is. If you have a blood test done and you get told that you're pre-diabetic, sometimes implementing changes or using these kind of lifestyle interventions can stop you developing diabetes, or it can make your diabetes more stable and less likely to, and that will mean you're less likely to experience side effects. Diet and exercise are the 2 big things. You need to monitor the energy that you take in and how you expend the energy that you do take in. You need to have regular checkups. regular blood tests to make sure that you are actually doing as well as you thought you were doing. You need to make sure that you manage your blood pressure and cholesterol. You need to look at foot care. That might seem like an odd thing, but as I described earlier, you start off with an ulcer on the tip of your toe, and then you lose a bit of your toe, and then you lose all your toe, and then some of your foot, and then your lower leg. You can stop that if you don't get the ulcer on your toe. Foot care, podiatry, that's how you do it. And you need to have regular checks of medication. For a very long time, in the beginning of my career, there were only 2 medications apart from insulin to manage diabetes, but now there's a whole heap more. The gliptins and others. So if you keep an eye on your medication, am I using the best thing? Am I using the best thing correctly? Could I do better with something else? Keeping an eye on your medications is a really good thing. And then you need to look at population level policies. So policies that promote healthy nutrition and physical activity can help prevent diabetes, which we've talked about. So there also needs to be other education campaigns around making sure that if you have diabetes, you attend to your checkups and that you keep an eye on your feet and that you take your medication properly and that all of the things. And here in New South Wales in particular, that it seems to be that public health units will cycle through a variety of campaigns. Just recently, my eldest daughter and I participated in creating some material to help First Nations people here understand about taking better care of themselves and not necessarily promoting a new drug, but explaining that new drug to people, because we noticed it was being prescribed, and the team at the university I used to work at, and I noticed that people were being prescribed this new drug, but there was a lack of it, culturally appropriate education material. So another population level thing, and this is something that the organisations I mentioned earlier, the Palestinian Diabetes Institute and the World Diabetes Foundation, have done is setting up diabetes clinics, both full service clinics to the community and better tertiary services for people who have to be hospitalised because of diabetes. Public health units can also, they employ a lot of epidemiologists, so they can do a lot of that statistical work around diabetes, the incidence, side effects, treatment, efficacy, all that sort of stuff. All the numbers things that I'm not very good at. But I'm sure I could be if I wanted to be. I just don't enjoy it. So the take-home message from today: with support and early intervention, people with all types of diabetes can live happy, healthy lives. Nurses in hospitals and the community provide much of the support and education for people with diabetes. So we need to know, and we need to do a good job about knowing. So our questions for this week, there are only 4, but they're a little bit bigger. Describe a way public health can use its services to help people with diabetes. So think back to a couple of weeks ago when we talked about what is public health and what do public health units do. We need to describe I need you to describe for me a health promotion activity aimed at people who have or are at risk of having diabetes. Bonus points if it's a program that you're familiar with. There are 2 articles that I've attached to the package. I copy and pasted, so the whole article is there. You don't need to follow links. One of them was a PDF, and if you don't pay for PDF, it can be hard to download stuff. So I just copied and pasted. So there are 2 articles that look specifically at diabetes and the public health response in Palestine. So I want you to think about what social determinants you think are at play for people in Palestine who have type 2 diabetes specifically, and describe services for people with diabetes that you are aware of in your area. So it doesn't matter where you live or where you used to live. Did you live somewhere that had one of the World Diabetes Foundation clinics had been set up in their area? Did people like it? Was it effective? Did it have such a long waiting list that people stopped wanting to go there? You know, there are lots of reasons. Was it a full service clinic? Could you go to one clinic and get foot care services and dietitian information and see a diabetes educator and see a diabetes nurse and all of those things all in the same place, and a doctor? Can't forget them, even if we want to. So that's it. Yep, that's it for this week. I was just checking in my brain, but I can't think of anything else that I needed to talk to you about. Anyway, that'll do. I just need to apologise. This is a day late because I was a bit crook yesterday because I wasn't in a kind of a car accident a little while ago, and whilst I wasn't very injured, I did thanks to the x-rays they took, find out I found out I had a medical condition that I didn't know about. So I've been very unwell in the last few weeks, and I probably should have communicated that sooner, but I kept thinking I could push through, like all nurses. I haven't coped very well with being the sick person. For someone with as many diseases as I already have, you'd think I'd be used to it, but I was not. Anyway, so hopefully I will get to look at the answers to your questions and all that sort of stuff today. Yeah. Anyway, good way you. Until next time. See you later.